Hi folks, my name's Hisham and I'm a psychiatrist in an NHS early intervention psychosis service in Peterborough in the UK. And this is part 2 of a 5-part video series on what I try and do in the psychiatric clinic. So this part is about clinical evaluation, and in most medical specialties, clinical evaluation involves a data collection exercise. So let's say you see someone, you take a history from them and you get a set of data points, and then you do an examination, maybe some investigations, and you get another set of data points. And what you're trying to do is come to some conclusion of what kind of illness process has generated the data that you've collected, right? And what you're trying to come up with is a probabilistic judgment of what might be the most likely cause or causes of the data that you've got. So in doing this process, you're collecting data points that have different magnitude, i.e. they may be quite small or they might be quite large signals, and data points that may have varying degrees of precision in that they may be more specific to pointing to a particular illness process or less specific. So to give you an example, fatigue is the kind of data that can often be of quite large magnitude, but it may not be very specific because it could occur with a lot of different kinds of processes. Okay, so to give you an example from somebody who once went to medical school, you can get a set of data points like this, but fever, cough, breathlessness, chest pain, and they may suggest that the underlying process that's generated this is a pneumonia. And that process will suggest that there may be other things that you could expect to find if indeed this is the process that's underlying the data that you're seeing. Okay? So what you're doing in the evaluation exercise is essentially detecting or collecting the data points, weighting them, and inferring the likely cause of the data by either doing a pattern recognition exercise or developing some model of what the generating process might be, or both. Very often what you'll find is edges of a particular pattern that will get you thinking about, look, might there be something else here that's generating what I'm seeing? And of course, what you do is then look for additional data points that would be suggested by step 3, okay? So in the psychiatry clinic, what kind of data do we collect? And I broadly think of this, and this is just a kind of shorthand way of thinking about it, is that we get various forms of story data, which is the content of people's stories, what happened and when. We get the structure of people's stories. Are people able to tell linear stories about what they've been through? Are they able to tell reasonably continuous stories about what they have been through? And this is important because there are various conditions which affect the ability of people to tell linear or continuous stories of their lives. Trauma is a very good example in which people may not have been able to form these kind of linear continuous stories of their lives. Thought disorder, which is a symptom that is a manifestation of mental disorganization that we see in psychosis, is another reason why people may not be able to give you the kind of linear continuous stories that we expect. But even when people can give us reasonably linear stories, it's important that we think about the actual complexity of those linear stories, because what often happens is people will go through event X, which affects their lives in multiple ways, and then shapes the trajectory of their lives in different ways. And it's important to think about all those various little steps and changes and how they've shaped people's lives, even when one thinks about a reasonably linear story. And the other bit that I throw in here is what I think of as systemic data. So thinking about factors like racism, like misogyny, like cultural factors, or the environments that people have grown up in, or the environments that people live in. This is additional stuff that we collect under this heading of what I think of story data. And then there's sort of non-story data. And non-story data can be relational, which is stuff that you pick up in the interaction between you and the person, or it can be non-relational, which can be observations that you may make of the person. And this has always been a slightly difficult area in psychiatry, because very often what people have done is commented on the aesthetic of people that they see, whereas what you're interested in is actually more sort of hard data rather than judgments about the person. And it's important to be careful about that. So you're interested if people may have, let's say, unusual motor symptoms that they're presenting with, but you're not interested in people's choices about how they dye their hair or how they choose to dress, unless these are representing some sort of change from a previous baseline for them. But if that's the case, then you really want to do the digging to find out, is this indeed a change? Now, we've got a particular challenge in psychiatry, which is that a lot of the processes that we're interested in and the processes that we look after aren't very precisely defined. So what we have are various models that might explain what is happening, and this applies across the various higher mental phenomena that we deal with. So when we're thinking about people presenting to us in psychiatry, often we need to think about multiple models of what might be happening for a person. So one could think of a model of a psychotic illness that may explain some of the data that we see. Think about a model of attachment difficulties that would explain some of the things that we see, a model of trauma that accounts for some data points, a neurodivergence model of ASD or ADHD that explains some of what we see, or an existential model that would explain some of the other data points. And very often these aren't exclusive. You could have parts of the same picture that may relate to very different models within the same person. But nevertheless, it's helpful to think about these sort of models, but for precisely that reason, that you could have multiple models in the same person. And it's important to think about all of them at the same time, because they may be relevant for different aspects of understanding what's happening to people, for different aspects of treating the difficulties that people have. That's one of the important bits of models, which is about understanding, but the other is also towards pointing to other data that you want to look at. Now, it's important to remember that when I talk about models like this, I'm talking about hypotheses, right? And these models will always be partial or incomplete or frankly wrong. So to cite this quote, whose provenance I can't quite remember, the best model of a cat is a cat, preferably the same cat. But what you're doing with the different hypotheses is that you generate them and you test them out. And one of the most important ways you test them out is with the person. Does this make sense? Does it seem to sort of explain or help understand what you're going through? And you correct these models as you go on. You let people know when you've made mistakes and apologize when you've made errors with the hypotheses that you've got. But the ultimate goal is to guide treatment, to help try and make predictions and improve people's outcomes as best as possible. So in the next part, I'm going to talk about diagnoses, formulations, and treatment.